Welcome. Roadmap to Residency. Hello, everyone. I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on your journey to a 250. You are currently in our nephrology modules, and this video is all about renal transplantations and rejections. In this video, we will be mainly focusing upon the theoretical part, the theory of renal transplantation, how it is done, what are the important steps, what are the complications that may arise, and how do we prevent those complications. So what is the next step in the kidney transplant process for these patients following the identification of a decreased donor kidney, of diseased donor kidney? So a 45-year-old woman with end-stage renal disease due to polycystic kidney disease has been deemed eligible for kidney transplantation. She has been on the transplant waiting list for 6 months. Recently, the transplant team informs her that a diseased donor kidney has become available and is and she is scheduled for the transplant surgery. What is the next step after you find the kidney? Immediate transplantation surgery, blood type and tissue matching, living donor evaluation, cross-match testing, or placement on the national transplant waiting list. So cross-match testing. So following the identification of deceased donor kidney for a transplant recipient, the next step is cross-match testing. Now this involves the mixing a sample of the recipient's blood with a sample of the donor's blood to check for compatibility and the risk of rejection. A negative cross-match indicates compatibility and reduces the risk of rejection during transplantation. Immediate transplant surgery. So cross-match testing is a crucial step before proceeding with the transplant surgery. Blood type and tissue matching are conducted earlier in the transplant evaluation process. Once a suitable donor is identified, cross-match testing is performed to confirm the compatibility. Living donor evaluation is relevant when considering living donor kidney transplantation. And in this case, the patient is receiving a deceased donor kidney. Placement on the national transplant waiting list and identification of a diseased donor kidney initiates the specific matching and cross-match processes. So this is the basic kidney transplant process. So first you need to evaluate the patient as, does the patient actually need kidney transplant? And we need to refer the patient to the transplant center. And in the transplant center, the medical evaluation is done, including blood tests, imaging studies, or other diagnostic tests, compatibility testing, including blood type and tissue matching, and is performed to identify suitable donors. And if there is living donor present, they undergo a thorough medical and psychological evaluation. Compatibility with the recipient is confirmed, and the risk and benefits of donation are discussed. So patients are deemed suitable candidates are placed on the national and regional transplant waiting list. Waiting times for a deceased donor kidney can vary based on factors such as blood type and availability of organs. So after that, you need to find a match. So for deceased donor transplants, the organ procurement organization matches available kidneys with recipients on the waiting list. After that, there is the transplant surgery, and then there is the post-transplant care. So after surgery, the recipients are closely monitored in the hospital for any complications. Immunosuppressive medications are prescribed to prevent rejection of the transplanted kidney. Recovery and rehabilitation. So recipients typically experience a recovery period during which they gradually resume normal activities. The ongoing monitoring and care. So long-term follow-up care is essential to monitor kidney function, manage medications, and address any potential complications. So you need to manage the immunosuppression in case of chronic kidney disease or in case of a renal transplantation patient. So immunosuppression is required for the life of the kidney. Modern protocols have dropped rates of acute rejections to 10% and increased 1 year graft survival to 90%. All immunosuppression increases the risk of infections and certain malignancy. All the side effects are specific for each agent. So the immunosuppressions that we generally use are polyclonal antibodies, cyclosporine or tacrolimus, glucocorticoids, basiliximab, sirolimus, or azathioprine. So calcineurin inhibitors are used to prevent rejection. The cyclosporine and tacrolimus are present here. They all have the similar modes of action. Both are nephrotoxic and they increase the hypertension in the patient. The more cosmetic changes are present with cyclosporine, and more neurotoxicity and diabetes risk is present with tacrolimus. But tacrolimus is superior in high-risk patient. Talking about steroids, which is the mainstay of immunosuppression since inception, but it does have significant side effects. The conventional dose blocks the interleukin-1 and high dose blocks the interleukin-2. So these are the dosages which are generally not needed for the examination. Sirolimus have a novel mechanism of action. They reduced The rejection, when they are combined with cyclosporin, the most difficult side effects of sirolimus are increased lipids, wound complications, and reduced white blood cell count. There is almost no role in orally post transplant and may switch if calcineurin inhibitor toxicity may be present in the patient. The recipient should be evaluated for active infection, malignancy, recurrence of primary diseases, early mortality, technical complications, non-compliance, or lack of social or financial resources. If the patient has malignancy, and for example, if the patient is having a renal malignancy, then there is no waiting period if there is incidental lesion. And if it is symptomatic, then we need to wait for 2 years. And but if there is a cyst, it is best to remove the cyst in the patient. If there is bladder, prostate, or testis cancer or malignancy, we need to wait 2 years. We need to be aware and need for the BCG vaccination, and there is evolving data which suggests the prostate cancer not a barrier, even it is treated or not treated in kidney transplantation. So there is one concept called as ischemia, which is reperfusion. So ischemia and reperfusion at surgery produce injury that can promote the inflammation and rejection. The delayed graft rejection, okay, the delayed graft function, DGF, is a strong predictor of graft survival independent of rejection. The pulsatile perfusion can improve early function, especially with long cold ischemia times. So the perioperative maneuvers include hydrate with colloid, mannitol, furosemide, intraarterial verapamil, or low-dose dopamine. So there are some intraoperative decisions which needs to be met in performing the renal transplantation. We need to preserve the lower pole arteries because we need to preserve the ureter. The right renal vein is used for the caval extension. We can use the cadaveric iliac vessels too. The conjoint arterial branches that are inside should be kept in consideration. The small lower pore vessel are end-to-end anastomosed with inferior epigastric artery. We can use ipsilateral native ureter end-to-end without native nephrectomy in the patients. So there is something called as early graft rejection. So we need to check the Foley's catheter, fluid bolus, Lasix, drug levels, and all. So whenever there is early graft rejection, we need to think for other differential diagnosis like acute tubular necrosis, acute rejection, drug toxicities. And if there is acute rejection, we can go for the treatment, steroids and antibodies like OKT3 antibodies. And the long-term issues could be chronic allograft, nephropathy, hypertension or diabetes, heart disease, infection, or erectile dysfunction. There is increased risk of CMV infection and BK virus infection in case of renal transplantation patient, and these concepts are generally asked in the examination. So CMV is also called as 42-day fever. It may be due to transmission or due to reactivation in the patient. So if the donor is positive, then to the recipient it is the highest risk. The prophylaxis. So for this, we give the patient prophylaxis with acyclovir and ganciclovir. It can cause disease in the GI, liver, glomerulopathy, or in the retina. So the BK virus is also called as the polyoma virus, and it is latent in the immunocompetent individuals. The diagnosis could be made by cytology and viremia and biopsy. The treatment is to minimize the immunosuppression. It can cause some genitourinary manifestations like nephropathy, graft loss, sterile pyuria, ureteral stenosis, and hemorrhagic cystitis. So these CMV and BK virus are very commonly tested in examination regarding the renal transplantation process. So now these are the re rejection, the host versus graft disease and all. So the hyperacute rejection is immediate. It is due to the performed antibodies, which is directed against the donor tissue. It can be caused by accidental ABO blood type incompatibility, which is very rare. And the type of hypersensitivity is type 2. So whenever there is rejection in weeks to months, we call it as acute rejection. It is due to the T cell mediated immune response directed towards against the foreign MHC, and the type of hypersensitivity is type 4. These type of hypersensitivities are important for the examination. The chronic, like months to years, when there is T cell mediated process resulting from the foreign MHC looking like self MHC carrying an antigen, it is type 3 and type 4. The graft versus host disease, the timeline varies. So there is bone marrow suppression, transplant, patient presents with diarrhea, rash, and jaundice. So when there is bone marrow suppression, defective RBCs are produced. When these defective RBCs are produced, these RBCs get lysed. And whenever these RBCs get lysed, there is jaundice. Okay. So it is a sort of type 4 hypersensitivity reaction. Thank you for watching. Keep studying.